Okay. Uh, so started recording. Hmm. I think you are having 7 pages. Okay, 7 rooms. Started your
Yeah.
timing. Okay, started. Next, shall I go to the next page?
Yes, ma'am. Okay. Okay, ma'am. Okay, ma'am. Yes, ma'am. Yes, ma'am. We can change.
Started your 10 minutes time. Started.
Hello, I'm Sija, one of the exam candidates today. I have read the scenarios and I'm ready for the structured discussion.
Okay. So you
Uh,
have to go to
I'll give
each
it.
case, summarize result, interpret the result. What are the abnormal things, and what will be your action?
Okay, ma'am. So my first case is a patient who is a 26 year old presenting with secondary amenorrhea. That's the situation and background. So I'll go with the assessment. I would like to assess her from her history, examination, and investigations. So from the history, I would like to know how long she is having the amenorrhea. When was the last periods? Before that, whether her periods were regular. Is she having any galactorrhea or headache or any blurring of vision, or is she on any drugs like any antidepressants? Is there any features of polycystic ovaries, and where there be any previous pregnancies? So I will also like to examine her, confirm her weight to height ratio, and look for any features of PCOS, and also check her field of vision. I would like to investigate her with repeat serum prolactin, also do a urine pregnancy test for her, and also I want to do an ultrasound to rule out polycystic ovaries. The TSH is said to be normal. And if the value is still high, I would like to do a multidisciplinary team and would like to refer her to the endocrinologist. And if it is still high, I would like to do a consider MRI as well, MRI brain as well. And if it is still high, I would like to start her on bromocriptine or cabergoline. Next, next, ma'am.
Okay. Mm.
Uh, Next is my situation here is a 26-year-old patient who is 12 weeks pregnant, presenting with urinary tract infection. Urine culture is showing Proteus species resistant to MOX and is only sensitive to Ciplox. In the background of a renal transplant for her. So I would like to assess with the history. With the details of the renal transplant, I like to go through the notes with her permission, the drug she is on, what all immunosuppressants she is on, any other comorbidities like diabetes or preeclampsia, when was her last specialist consultation, at present is she having any fever or dysuria, and how is the pregnancy going. The examination, I would like to look for her BP, her temperature, any pedal edema or renal angle tenderness. And investigations, I would like to know whether her blood tests were done or NT scan is done. What is her albumin creatinine ratio and what is a renal function test. And also, as she is having a renal transplant, I would like to continue serial growth scans for her from 26 weeks. So, as here the Ciplos is the only medicine that we can give, considering the benefits outweighing the risk. So, I would like to offer her Ciplox itself. And once the treatment is over, we'll repeat the urine culture cells. Also, I will counsel her about the minimum risk that Ciplox can have on the baby. Next one. Next situation is a 30-year-old patient. She is 16 weeks pregnant, and her 16 weeks down test was done, and her alpha fetoprotein is found to be raised. In the background, she is an epileptic. So I would like to assess her about the pregnancy. She is 16 weeks, whether her basic blood test is done, her NT scan, and was the double marker test was done or why it was missed. And when was her last seizures? Is she seeing her specialist? Was this a plant pregnancy? Is her high folic acid, that is 5 milligram folic acid, was started? I'll also like to examine her and investigation as she is having a raised AFP, most probably she is going to have a neural tube defect. So I would like to refer her to the fetal medicine specialist and get a specialized scan done for her. If the fetal medicine specialist is referring for an might need an amniocentesis, and if according to the results and assessment, I would like to offer her the options of continuing the pregnancy or terminating the pregnancy. Next one. Madam, next.
Hmm.
So next, I have a situation where the 31-year-old second gravida at 28 weeks of pregnancy have done her 75-gram GTT report, and the FBS is 5 millimole per liter, and the PPBS is 8.2. So as the fasting level is normal, but her 2-hour level is on the higher side. The cutoff being 7.8. With the background here, there is a previous baby having a baby weight of 4.5 kg, and her mother is diabetic. So I would like to assess her, take the history, her present pregnancy history, what are antenatal complications are there, what are the tests being done, how is the well-being of the baby, and also I would like to know about her past pregnancies. The 4.5 kg baby, how was it delivered? Was it normal delivery? Was there any shoulder dystocia? Is there any history of any postpartum hemorrhage? How was the sugars after the delivery at 6 weeks? I would also like to examine her weight to height ratio, and also per abdomen. I would like to know her symphysiofundal height. Investigations, I would like to go for a serial monitoring of sugars. Since the sugars are on the higher side, I would like to have an MDT team like a dietitian and the joint diabetes and antenatal clinic to be involved here. So first 1 to 2 weeks, I'll be asking her to take care of her diet and exercise for around 30 minutes after every meal. And if it is still not been in control, we'll be starting her on metformin. If there is any contraindication for metformin, we'll be starting her on insulin. Madam, next. Next, ma'am.
Hmm.
Next, the situation is Mrs. Baby. She's 24 weeks pregnant in a second pregnancy. Her Andy C is found to have been raised, that is 12 units. In the background, that she had severe PPH with blood transfusion in the first pregnancy. So I would like to assess her regarding how the present pregnancy is till now, any complications till now, what is a blood group, what happened in the previous pregnancy. I would also like to go through the notes, how many blood was transfused and how was her recovery. I will also like to examine her size of the per abdomen, the size of the baby. Investigations, I like to do her basic investigations, and sometimes an NIPT or a paternal testing might be needed here. Since the anti-C is more than 7.5 international units, there is a moderate risk of hemolytic disease of newborn. So, and anti-C should be measured every 4 weeks. Till 28, and then every 2 weeks. Also, I'll refer her to the fetal medicine specialist, and there she might need weekly MCA Dopplers. Next, ma'am. Ma'am, next. Madam, next.
Yes, done.
Okay, ma'am. The next case, my situation is a 57-year-old lady presenting with history of postmenopausal bleeding with biopsy showing only chronic inflammatory cells with no evidence of atypia. In the background, that she is having a history of breast cancer and she is on tamoxifen. So I would like to assess a history with presenting complaints. If this is a first episode, when was her menopause, how is she after the procedure, and also I would like to examine her local examination, per vaginal examinations, whether smears has been done. If not, I'll be doing a smear. But as tamoxifen is a high risk factor for endometrial hyperplasia and endometrial cancer, I would like to directly go for a diagnostic hysteroscopy with endometrial sampling for this patient, as ultrasound is neither specific nor sensitive for this baby patient. Next one. Ma'am, next. The next last case is a 30-year-old woman. She's presenting with a primary infertility with a 21-day progesterone showing a value of 1.9, which is low, and that means she is anovulating. She is having anovulatory cycles. In the background of irregular cycles, the other value of FSH is normal. So I would like to assess her with history, how long she's trying to conceive, any contraceptions till now, any features of polycystic ovary, how's her support as she is going through infertility, and if need for any counselors. How's the sexual history? Yeah, or what is the frequency of sexual intercourse? I will also examine her for all the weight to height ratio and features of polycystic ovaries. I'll investigate her for primary infertility like ultrasound, tubal test, ovarian reserve. And as she is not ovulating properly, I would like to go for a follicular study with the help of a multidisciplinary team and a fertility specialist. And also, I would like to do a serial serum progesterone for her. Yes, ma'am.
Okay, good. Okay, and done. Done now.
Yes, ma'am.
Okay. Anybody wants to comment on her performance? Well done, Sija.
Thank you, ma'am.
Anybody? Please give feedback.
No, with respect to the task, too much history is not needed.
Yes, not needed. This if it will be a simple task, be strict to your specific history. Okay. Do not ask a
Okay.
generalized history. You will be downgraded in information gathering in that way. Yes,
Okay.
history is important, but then what history? The way in hyperprolactinemia you mentioned that I would like to take the history of her ophthalmic symptoms, headache, breast engorgement, menstrual cycles, and any antipsychotics. So those history is very important. Apart from that, no need to offer her examination on all those things. The
Okay.
interpretation is very important. Relevant history is important, but everything is not important in that task. And examination is not indicated in all the tasks because you offered almost examination in all the tasks. Okay, I would like to examine her,
Yeah.
examine her. Yeah, so they will downgrade you. Be specific. If you think okay, she requires examination, then only say. Otherwise, don't. In aneuratory cycles, yes, you can ask. I would like to know her BMI also because she's having annual cycles. She might be in a spectrum of PCOS. Okay, so you justify why you want to know the information. Don't just ask blindly. Hmm? Justified information at least will give you mark. If unjustified information you are going to gather, you may not get, and you may get downgraded also. Okay, so that is one
Okay, ma'am.
suggestion. Anybody else wanted to comment? Anybody else? No. Hmm? And the way you mentioned, I wanted to know galactorrhea, headache, all those things. So this is not a single task where you do not have that much time also to ask. So I will say I would like to elicit the history suggestive of prolactinoma.
Okay.
Okay, so in one word, you are telling your examiner that what you are going to look for. Hmm? So
Okay.
that is one thing. Okay, now coming to the answer key. Very well done, but very well done. Okay, so identify situation, anticipate risk and complication. You were missing out on this anticipation of risk and complication. So see to it, you will be telling it loudly because RCOG is fond of implication, anticipated risk and complication. Say it loudly.
Okay.
She is at risk of, okay? Something like that. Do not read whatever information has been given to you. You were reading it out and you were mentioning situation background. No, don't do that. Just identify the situation. So you can make it out. Oh, she is a case of hyperprolactinemia. Okay, something like
Okay.
that. Okay, and then background you can mention with all these things. Then that background is okay. So with this hyperprolactinemia, this are symptoms. So something like that. Anticipation of risk and complication is important, and what measures you are going to take to minimize that complication. Okay. Oh, minute. Okay, so this is not needed. Hmm. Okay, so secondary amenorrhea due to hyperprolactinemia. It could be anticipated risk could be pituitary microadenoma, but yes, you wanted to rule out urine pregnancies. That is another issue. So yes, you have to invite patient for history, evaluation, even ophthalmic references because the patient might have some ophthalmic symptoms. So she needs to be evaluated by ophthalmic reference. Repeat test. Okay, so she needs repeat test, and if the levels are still high, more than 1500 or more than 1000, then we need to refer her to the endocrinologist, consider MRI, CT of the brain, offer patient information leaflet regarding the same. Okay, implication of hyperprolactinemia on her will be risk of amenorrhea. Yes, risk of amenorrhea,
Yes.
and she needs treatment according to the accordingly. So it can be either dopamine means bromocriptine or cabergoline, or the other options will be depending upon the CT evaluation, it might be a surgery. So that part can be taken care by the endocrinologist. Hyperprolactinemia, yes or no? TSH is normal, other hormones are normal. So this is what the guideline is saying. Okay, so this is actually previously it was there this strat OG, so I have taken it from the strat OG only. So if it is 500, less than 500 milli international unit per liter, this is normal range, nothing to be done. If it is less than 1000, it could be because of the stress or breast examination. So repeat, okay, repeat. But you can just repeat and wait and watch. If it is in between 700 to 2500, it could be hypothyroidism, it could be PCOS. Check thyroid T4, which was normal, FSH, LH, testosterone, and SHBG. In this case also it could be PCOS. Okay, so you can offer her USG also. You, as you rightly mentioned that you had offered USG to rule out PCOS. Less than 3000, non-functioning microadenoma, MRI, CT, hypothalamic tumors, non-functioning, and if it is 1500 to 4000, it will be functioning microadenoma. So evaluation, endocrine reference, and depending upon the type of tumor, either medical line of management or surgical line of management, they will be deciding. Threshold for offering imaging is more than 1500. Okay, so this is very important. Renal transplant, high risk pregnancy with renal transplant, untreated infection can lead to pyelonephritis and cystitis. In eventually, it might lead to miscarriages, PPROM, and preterm labor. Yes. So here the benefit is more than the risk, and this will be explained to the patient, explain the benefits and risk associated with ciprofloxacin during pregnancy on mother and baby. Ask GP to prescribe antibiotic to the patient. Counsel about the contraindication of this medication in pregnancy. Repeat urine culture after completion of treatment. You mentioned serial monitoring of renal parameters. Okay, because it's a renal transplant case, so we need to follow the monitor her and along with the routine renal care, she will be in a joint care here. She will be in a joint care, that is renal transplant nephrologist and consultant obstetrician will be a part of her team along with GP and community midwife. Watch for other complications of renal transplant. You can just mention that also. Okay. But here, as of now, if it is a stable graft with only UTI, continue ciprofloxacin. Raised alpha fetoprotein, yes, you had mentioned at risk of aneuploidy and at the same time neural tube defect. Very nicely, you had mentioned that. Detailed history here, you wanted to review her case detail about the double marker and not scan. No, it is anti-scan. Okay. Refer her to the fetal medicine expert unit where you will be counseling her regarding the NIPT and the invasive testing. Invasive testing at 16 weeks of gestation will be amniocentesis, but a detailed anomaly scan from a fetal medicine experts to rule out NTD, which might have been missed at 11 to 12 weeks. So, rule out NTD. Pros and cons of amnio, NIPT. NIPT is a diagnostic, not a confirmatory test. Trisomies and NTD, trisomies like 21, 18, 13 and NTD NTD is a high possibility because she is on antiepileptic. No? So would like to review her medications, what type of antiepileptic she is on and what was the dose of folic acid. Discuss the reports once available. Discuss the reports and results with the consultant, and depending upon the options we can discuss the further management, either TOP, that is stop termination of pregnancy, or antenatal care if reports are normal or according to the patient wishes. Okay. Exclude history of bleeding in pregnancy. No, this is not actually this. Okay. Now, abnormal OGTT, it was abnormal here. Why you had gone into that metformin and insulin, I don't understand here. So, you mentioned that the FBS is normal. It is only that PGBS which is abnormal. So, serial monitoring of the blood sugar is indicated here. And she will be referred to the dietitian in diabetic clinic. She will not be offered a diabetic clinic. She will be referred to the dietitian, okay, for diabetic diet monitoring. Serial glucose monitoring and consider metformin if no control. Don't go beyond metformin here. Most of the time, if it is just impaired, she will respond to the metformin. Less likely she will be needing, or you just modify your sentence, since it is just a impaired glucose tolerance. And if she develops GDM, she will very well respond to the metformin. Less likely she will be needing insulin. Okay, you can use that sentence in a different way. Serial fetal growth scans is needed because her previous birth baby is 4.5 kg. You wanted to know previous mode of delivery, previous complications, and okay, because you are keen on managing her further. Doppler assessment is also important. If everything is normal, reassurance. If GDM, it will be again joint care. This actually you had just mentioned only few points. We need to discuss many points here. So anti-C antibodies, that is isoimmunization with raised anti-C antibodies. This is her second pregnancy, and the first pregnancy was complicated by PPH at 24 weeks of gestation, and she's at 24 weeks of gestation. uh, now she is anti-C antibodies positive. Here onward, you cannot say that you would like to screen her anti-C antibodies every 4 weekly till 28 weeks and then after that 15 days. No, now she had come positive. So your urgent intervention will be referring to a fetal medicine unit because the baby is at risk of hemolytic anemia, jaundice, hemolytic disease, jaundice, including fetal anemia and hydrops. So you are going to refer her. Serial measurement of anti-C antibodies, refer to fetal medicine unit for monitoring with middle cerebral Doppler PSV. Depending upon that, blood transfusion accordingly. Okay. What was her previous pregnancy, whether it was affected or not affected, that also we need to find it out by accessing the previous case details. um, Joint care consultant, hematologist, neonatologist, fetal medicine expert assess need for any other red cell antibodies, and patient is previous PPH, so she is at risk of repeat PPH. She need to be booked at tertiary care center where risk of PPH and cell salvage facility will be available. Active management of third stage of labor and minimize blood loss at that time. Okay. Difficulty to have keep and keep cross match ready, always ready with this antibody patients. Okay. This was very nicely mentioned by you. So very well mentioned and very precisely mentioned that non-specific inflammatory endometrial changes, TVS will not be an option here. So hysteroscopic biopsy will be an important investigations which you would like to go. If normal, reassurance. If abnormal, further guidance accordingly. Okay. But if normal, still the patient will be kept on follow up on TVS. That is my option here. Okay. So if it is normal, we can follow up these patients with symptom, if means with TVS follow, because the patient is on tamoxifen because of CA breast. Annullatory progesterone level. Yes, here you mentioned MDT. What do you mean by MDT when it comes to in the beginning only? Here you have diagnosed it. You know that this is annullatory progesterone. So you can give her ovulation induction with serial monitoring of ovulation. Assess response after 6 cycle. If no response, then fertility reference can be done. That is the management here. Okay. Along with that, you very nicely mentioned that you wanted to know because she might be PCOS, so you wanted to know about her BMI. BMI is high, then patient can be offered lifestyle modalities also, that you can also say. Very nicely you had mentioned that. So overall, a good presentation, but don't generally ask all the information you are going to ask. Relevant is information you are going to ask, and if you are going to ask anything, justify.
Okay.
Okay. So information gathering in this thing is able to interpret information from the investigations appropriately, able to initiate additional investigations to help a plan management for each case, has an understanding of additional information that may be required to help arrive a diagnosis and plan care. Introduce, okay, communication with patient and family, if it has been there, introduce in the generalized statement, you can say that I will be introducing myself to all the patients and consent for continuation of the consultation. Give information sensitively and manageable amounts regarding results of investigation in and management of each pregnancy. Clear logical action, rational for a follow-up. Colleague, how your ability to prioritize cases appropriately, refer them for timely intervention, investigations, recognize the importance of time, especially in relation to the prenatal diagnosis, describe the differential diagnosis, formulate appropriate management plan, refer to appropriately to fetal medicine and other discipline. Patient safety, understanding your limit, ability, and demonstrate an understanding when to refer to the patient to the senior colleague and other discipline. Risk of intervention, investigation, procedure, take necessary precautions against it. Applied clinical knowledge, basically having a knowledge of RICE and RCOG pertaining to each topic is important. Okay. That is what this task is about. Imaging, investigation, management of pregnancy, present management options and their risk and benefits using non-directional counseling, and knowledge of NICE and RCOG. Okay. Overall, a good task. Now, Dr.